Thank you, Jonathan.
Yeah.
Jonathan, I was asking you anything interesting that you're working on recently?
Yeah, I'm doing some fun international health. I've got a fun paper on privatizing diabetes care in Mexico, where we show we really improve diabetes outcomes by offering a private alternative to their public health system. And I've got a fun paper on the largest health insurance program in history, the Chinese new cooperative medical scheme, which we estimate saved about 1 million lives a year.
Wow.
So, yeah,
Chinese,
so really,
huh?
Yeah.
Of all the people, I would have thought. That's interesting. That's very interesting.
Yeah.
So as people are coming in, I'm going to give about another minute, and then I will start with the introduction of the talk, and we'll proceed from there.
Great.
All right, looks like we have more or less stabilized at the number of participants. I wanted to welcome everyone to the 20th annual Wayno Peel Lecture in Economics. My name is Shushan Danagulian. I'm an assistant professor at the Department of Economics. And before proceeding, I would like to thank the Office of the Dean of the College of Liberal Arts and Sciences, specifically Dean Hartwell, as well as her staff, for helping us put this event together. And today is March 23rd, and the choice of the day was not random. In fact, today is the anniversary of the Affordable Care Act. So today we would like to wish a happy 11th anniversary to the Affordable Care Act. And to celebrate the occasion, we have asked Dr. Jonathan Gruber to join us in celebrating the occasion and telling us what he thinks lies in the future. So before we start with a lecture series, I would like to lay out some of the rules for the lecture. Dr. Gruber will present his thoughts and comments moving forward with the ACA for the first about 30 to 40 minutes of the presentation, and then we will open up the lecture to questions. Questions can be asked using the chat feature of Zoom. So please put your questions in the chat feature, and I will summarize the questions and ask them myself. I will moderate the talk, and I will allow us to ask as many questions as we can fit in the time period we have. So without much more ado, I'm going to introduce Dr. Kevin Cotter, who is the chair of the Department of Economics at Wayne State, who will tell us about the lecture series as well as our speaker. Kevin, take it away.
Okay, thank you, Shushan. So welcome, everybody. Good afternoon, and welcome to the 20th annual Wayno Peel Lecture in Applied Economics. Wayno Peel received his PhD in economics from Wayne State in 1977, which led to a successful career in consulting for the financial and banking sectors. He worked at Accenture, Arthur Andersen, and A.T. Kearney. Dr. Peel made a generous gift to Wayne State University to establish an annual lecture series in applied economics with a matching contribution from Arthur Andersen. Previous speakers in the series have included Stephen Levitt, Alan Deerdorf, John Kennan, Eric Kanishek, and Jennifer Ruger. So now I'm very excited to introduce today's speaker. Jonathan Gruber is the Ford Professor of Economics at the Massachusetts Institute of Technology. He was a key architect of the Massachusetts Healthcare Reform Act of 2006. Dr. Gruber then helped design the Patient Protection and Affordable Care Act of 2010, exactly 11 years ago, also known as Obamacare. He has published more than 180 research articles, edited 6 research volumes, and written 3 books on health economics, including a graphic novel on healthcare reform. Dr. Gruber has been consistently recognized as one of the nation's most influential people in healthcare, and he received a Guggenheim Fellowship in 2020. So please join me in virtually welcoming Dr. Gruber to Wayne State. So please go ahead.
Thank you. Thank you, Kevin. It's good to virtually be here. I'm sorry I can't be there in person. Nice that the sun is shining, and hopefully that's a sign for the optimism that we'll soon be able to travel again and get together in person. Yeah, it's great to be here on the anniversary of the ACA. It's sort of funny, when the ACA passed, I already had a trip scheduled. So my very first speech on the ACA was actually in London, which was sort of odd. So it's nice to be here speaking on the anniversary. And so what I thought I would do is I'd talk a little bit about a little history. We can't really understand where we are and where we're going without the history. And then I'd really focus on sort of where we're going next with the ACA and healthcare reform more generally in the US. And then I'd love to get a discussion going. So I think with the history, there's no better way to understand the history than to start with a story of two women. One is Andrea. Andrea was a 35-year-old mother of three small children when she was diagnosed with breast cancer in the early 2000s. Fortunately, her husband had excellent health insurance, so she was able to get the preventive care she needed, including preventive mastectomy. But several years later, when symptoms persisted, additional testing showed that she actually carried the gene for breast cancer, 1 in 800 chance, just because of no family history. Fortunately, once again, because of her excellent health insurance coverage, she was able to get the additional preventive care she needed, additional surgical care she needed to make sure that cancer did not reappear. The other woman was Hillary. Hillary was a single mother of two small children, also in the early 2000s, when she felt a lump in her chest. A state screening program paid to have it screened, and a state health insurance program paid to have a lumpectomy to remove the cancerous growth that had come in her breast. But several years later, she no longer had state coverage. She was working as a waitress, and she didn't have health insurance, and she felt a pain in her chest. Now, despite her history, she decided not to go to the doctor to get care because she was uninsured in her job and was afraid she couldn't pay her bills. By the time she went to the emergency room with dizziness, a number of months later, the cancer metastasized all through her body. Now, the first of these women, Andrea, is my wife. And I'm pleased to say that today she's healthy and cancer-free. The second of these women died shortly after that visit to the emergency room. These are two women diagnosed with the same diagnosis at roughly the same age, at roughly the same time. And yet they had diametrically different outcomes. And that is not just an isolated example. That speaks to the enormous disparities in healthcare that exist in our country, and in particular existed before the Affordable Care Act. America, despite being the wealthiest nation on earth, had dramatic differences in access. Differences such as the fact that a white baby born in America has the same chance of seeing their first birthday as one born in Northern Europe, and a Black baby has a lower chance than one born in Barbados. Differences that lead to the kind of outcome effects that I described. And a major source of these outcome differences is a lack of health insurance availability. Okay. Now, before the Affordable Care Act, which is not that ancient history, 11 years ago, 11 years and a month ago, in the US, most Americans had health insurance. About 60% of Americans got health insurance through their employer. That health insurance had some issues. You know, people might not have liked the deductibles or premiums, but by and large, folks are pretty satisfied with that insurance. Another 20% of Americans got insurance through public insurance programs, the Medicare and Medicaid programs. Medicaid is the program for the poorest Americans. Medicare is the program for the elderly. And those individuals are once again, by and large, satisfied with their insurance. But the other 20% of Americans were essentially uninsured. Now, what I mean by essentially uninsured? Well, that group consisted of two groups. 3/4 of them were actually literally uninsured. The other quarter had something called non-group insurance coverage or individual insurance coverage. This was insurance that was not purchased through your employer, but purchased on your own in a market where it was perfectly legal for insurers to discriminate against potential customers. Insurers could deny coverage. They could charge the sick many multiples of the healthy, or they could exclude pre-existing conditions, such as cancer, from coverage. As a result, individuals in this market were fundamentally uninsured. Yes, they could buy insurance, but they could lose it once they got sick, and they might not ever get it again if they got sick. So essentially, we had a situation where for 80% of Americans, the system was working. They were getting insurance. For 20%, the system was fundamentally broken. They were in a discriminatory insurance market where they could not get insurance at an affordable price to protect themselves against illness. Now, this wasn't something Americans were happy about. Americans are by and large good people. They didn't like this discriminatory feature. But it turned out to be a difficult problem to take on. It was a difficult problem to take on because of the problem economists call adverse selection. Okay, and what we mean by that can be seen in an example, which is 7 well-meaning states in the 1990s decided we are going to take the step of banning the ability of insurers to discriminate against the uninsured in our individual insurance markets. We'll say insurers have to give insurance to anyone who applies at a common price, what's called community rating. You can vary it by age, but if any 55-year-olds who come to you, doesn't matter if they're coughing on the way in, you got to give them insurance at the same price every other 55-year-old. And they passed those regulations. The insurance company said, wait a second, you're telling us that we have to provide insurance to anyone who shows up at a common price, and yet people can wait until they're sick to show up. Well, then we're going to lose our shirts. People are going to stay uninsured when they're healthy. The minute they get sick, they'll get insured, and we're going to lose money. We're going to go out of business. So the insurer said no thanks and left the business. And in all 7 states, the non-group insurance market collapsed. In all 7 states, rather than obey these regulations, insurers just said, well, one way to avoid the regulation is just to not sell insurance in the non-group market, and they didn't. And the insurance markets collapsed. Now, one of these states was my home state of Massachusetts, and our non-group insurance market was a disaster. Fortunately, we had a very visionary governor, a Republican governor, Mitt Romney, who really thought it was unfair that we tell insurance companies to cover them with insurance, but we don't tell people that they had to buy insurance. So Romney proposed that we bring in what was called the individual mandate, a rule that individuals had to buy insurance, whether healthy or sick, and essentially strike a deal with the insurance companies. Say, look, insurance companies, you have to charge everyone the same price, but in return, we'll make sure it's not just the sick who buy. We'll make sure everyone buys. Now, of course, you can't mandate people buy something that they can't afford. And so Romney also introduced proposed a new program to be called Commonwealth Care, which would subsidize health insurance costs for low-income individuals. So I'll refer a number of times during this talk to the poverty line. The poverty line in the US is a construct, a really relatively arbitrary construct that measures whether people are resource constrained. It's set at about $13,000 for an individual and about $25,000 for a family. So in Massachusetts, we set up to about 3 times the poverty line, or for families up to about $75,000, we would make health insurance heavily subsidized. And that became what I call Massachusetts' 3-legged stool. Fair insurance pricing, an individual responsibility requirement, and subsidies to make health insurance affordable. And this 3-legged stool worked. It worked quite well. We reduced the uninsured rate in Massachusetts by 2/3, down to 3%, the lowest compared to a national rate of 18%, or comparable to many European nations. We reduced our premiums in our broken non-group insurance market by more than 50% relative to national averages. And we, by and large, left the vast majority of Massachusetts residents alone. Those who had employer-sponsored insurance, those who had government insurance, who basically said, look, the system's working for you, we'll leave you alone. As a result, it was very popular. It had about 2/3 public support in the state, and it was very successful. So successful, a number of other states in the wake of Massachusetts' success decided they'd try their own systems. But in every case, they realized that it was just too expensive. Massachusetts had a number of financial advantages. We had a low number of uninsured. We had a large level of federal support, and other states realized they couldn't afford to do this. And so all eyes turned to the federal government. And this was a strong topic of conversation during the 2008 election. And President Obama got elected in 2008 with a mandate to take this on. And he took it on by essentially adopting the Massachusetts model at the national level. As one of my colleagues in Massachusetts said, it was the Massachusetts model with 3 more zeros. So basically, it was the same 3-legged stool, which was ban insurer discrimination. And once again, I cannot overstate, this is the single most important part of the Affordable Care Act. Okay, no longer in America could insurers charge women more for insurance than men, tell a kid they can't get insurance coverage because they have asthma, turn down a cancer survivor for insurance coverage. A basic human right was finally enshrined in law. Okay, this is a fundamental accomplishment for our nation. Pairing that with an individual mandate, the way the individual mandate worked was individuals had to buy insurance or pay a tax penalty, but if they could not find insurance for less than 8% of income, they could be exempted from the mandate. So it's really a mandate on those who could afford insurance. And then finally, a 2-part strategy to subsidize insurance for the low income. One is an expansion of the free Medicaid program up to 133% of the poverty line. So we're talking about low $80,000 for a family. And then tax credits on the new Obamacare exchanges, the new state exchanges, which were a place people could turn to buy health insurance from insurance companies. They could do so with a tax credit, which would limit what they'd have to pay as a share of their income. This was put into place, and it was passed in 2010, 11 years ago. It was implemented 4 years later, almost 4 years later. The beginning of 2014 is when it really sort of took effect. And the short-term effects on policy grounds were quite positive. Within a few years, the program was covering about 20 million Americans. It had stabilized our broken non-group insurance coverage, and early evidence suggested it was improving access and even health. The problem was, while the law was a policy success, it was a political failure. Now, partly, this is because there was a 4-year gap between when the law was passed and when it took place. That left 4 years for opponents of the law to vilify it in theory, while supporters had nothing tangible to point to in practice. Then, when the rollout of the law in late 2013 was marred by website glitches, it just exploded. It fed the narrative law as a failure, even though 6 weeks later those glitches were fixed. It was too late. The narrative as a failure was set. And as a result, it was hard to break through with the good news the law was working. And the Affordable Care Act became political liability. Enough of political liability that it was an important factor in delivering both the presidency and both houses of Congress to Republicans in 2016. With a law that was much less than 50% favorable. They ran on repealing and replacing the Affordable Care Act as a key linchpin of their campaigns. And on November 4th or 5th, or whenever it was, 2016, it certainly looked like the Affordable Care Act was dead. You had a president and a completely Republican-controlled Congress who'd made perhaps the policy centerpiece of their campaign, repealing and replacing the ACA. But then a funny thing happened. As we rolled into 2017, the Affordable Care Act had been around for a while and people started to appreciate what it was doing for them. Meanwhile, it turned out repeal and replace was really just repeal and repeal. There was no replace. There was no real plan to replace the Affordable Care Act with anything. The proposal was just to repeal it. Indeed, to be honest, it was more than that. What Republicans proposed was to repeal the Affordable Care Act and also to slash Medicaid. So that as a result, the CBO estimated that under one Republican estimate, the number of uninsured in America would rise by 32 million people, well above the 20 million that had gained coverage from the ACA. There'd be even more people losing coverage because Medicaid would be cut. And suddenly, the Affordable Care Act became popular. Suddenly, in early 2017, the popularity of the Affordable Care Act crossed 50% for the first time. And the Republican majority was unable to repeal the Affordable Care Act. I think what we'll never know is that they'd move quickly to just repeal it and not try to take on Medicaid too. Might it have passed? I think there's a good chance it might have. But in any case, it didn't, and the Affordable Care Act survived. But it didn't survive unscathed. During the 4 years of the Trump administration, the Affordable Care Act took a number of hits. The individual mandate was repealed. Efforts that the government make to try to do outreach to bring the healthiest individuals into the insurance pool were curtailed. New insurance options, which essentially skirt the regulations of the Affordable Care Act, were allowed. And as a result, you had a situation where the number of uninsured covered by the law fell by several million people. And premiums on these Obamacare exchanges got very, very high, to the point where essentially health insurance was unaffordable on the exchanges unless you had a tax credit. Tax credits under the exchanges go up to about 4 times the poverty line, or about $100,000 for a family of 4. Unless your income was below that level, and even for any people below that level, it was just unaffordable because the exchanges, the premiums had gone through the roof. Now, where did that leave us? Well, interestingly, that left us with a system that was largely working for the poor and not the middle class. So essentially, it left us with a system that was really, in some sense, what Democrats wanted at the start, which was Medicaid expansions and tax rates for low-income people. It was a sort of bipartisan middle-class success of the bill that really suffered. It was the people who are middle class could no longer afford insurance on the exchanges. But it also had one other fundamental flaw that was not foreseen by designers of the law, which was that in a Supreme Court decision in 2012, it was made, states were allowed to elect whether to adopt these Medicaid expansions. Now, when that decision came down, no one thought much of it, because the way the Medicaid expansions work is the federal government says to states, if you expand Medicaid to people below 133% of the poverty line, Medicaid's a state-run program. If you expand below 133% of the poverty line, we will pay 90% of the costs. Well, that's an unbelievably good deal for any state. And indeed, any state that didn't take that would be committing political malpractice. Because if you simply look at the money that would flow into a state, if you look at simple economics of multipliers, states would make money while covering their own insurance. It was literally a win-win for every state. And despite that, a number of states out of pure political spite did not expand Medicaid. And even today, 12 states continue to not expand their Medicaid program. That's a problem, because since the ACA wasn't designed to allow for that, people cannot get into the ACA exchanges unless their income's at least at the poverty line. So this crazy hole in the Affordable Care Act, where in 12 states, if you're above the poverty line, you can get insurance on a heavily subsidized basis. But if you're below the poverty line, you can't get coverage. It's crazy. So where does that leave us? That leaves us in a situation where the Affordable Care Act became an asset, not a liability, during Joe Biden's campaign. And the success of the Affordable Care Act was a positive in his getting elected. And certainly in the 2018 elections, the concerns about losing pre-existing conditions coverage was a major feature in Democrats taking over the House of Representatives. So where does that leave us now in terms of the Affordable Care Act? Well, the Biden administration came in proposing a number of changes to improve the Affordable Care Act. And in the recently passed American Recovery Act, some of those changes were embedded. Most notably, ending the so-called subsidy cliff for exchanges. Remember, I said you can get tax credits up to 4 times the poverty line. But remember, I also said premiums in the exchanges have gone through the roof. What that meant is there was this huge cliff where you're below 4 times the poverty line could get subsidized coverage. Once you went to 401% of the poverty line, coverage became unaffordable. So what they did is they ended that cliff. Everyone now can get subsidized coverage on the exchange at all income levels. They also made those subsidies a little more generous at the bottom of the income scale as well. They made it free for those below 150% of the poverty line. So they made those subsidies more generous and really brought a whole swath, more than 1 million people, the CBO estimates, a whole swath of middle-class people now be able to come into the exchanges on a more affordable basis. But that's only for 2 years. It's a 2-year temporary fix. They also, as part of the ARA, as a temporary fix, allowed people who are unemployed to immediately get access to the exchanges. They reopened the exchange open enrollment period so people could get on the exchanges now. And they included more funding for outreach, so individuals could go and get the coverage, so they could reach out to individuals and let them know they're eligible for health insurance coverage. So those are major changes, but it's only part of what the Biden administration has proposed. So the Biden administration has really proposed 4 pieces for ACA reform. The first piece is really kind of undoing Trump. getting rid of a bunch of regulations which really undercut the ACA. Regulations which, for example, allow people to buy sham health insurance. One of the major accomplishments of the Affordable Care Act was banning sham health insurance. People would buy health insurance which would run out after you spent $10,000 at the hospital. Well, I don't know how many of you have been to the hospital, but you can't go in and sneeze without spending $10,000. Okay, so basically banning coverage which only lasts a couple of months or wouldn't cover certain diseases. That's not insurance. But that's not insurance. It's described as not insurance on page 73 of the fine print. So many people would buy that and only realize too late they didn't have coverage. President Trump allowed those programs to be sold, and President Obama will hopefully ban them again. President Biden, I'm sorry, hopefully ban them again. Things like expanding outreach and expanding access to the exchanges. That's one suite of changes which will happen. A second suite of changes is improving affordability on the ACA exchanges. And as I said, we've got a temporary fix to that under the American Recovery Act. Hopefully, in the next round of legislation, there'll be a permanent fix to make exchanges more affordable. Importantly, that needs to include not just addressing the premiums, but also people have to pay out of pocket. Many low-income people on these exchanges are asked to pay a lot out of pocket, and we need to address that as well. And President Biden's proposed that, moving the default plan from the so-called silver plan, which is very skimpy insurance, to gold, which is a more generous insurance plan. So helping people out to not only make premiums more affordable, but also to be able to cap their out-of-pocket costs. They're not exposed to too much spending if they need to buy insurance on the exchange. So that's the second piece of his proposal. As the first piece, that's a no-brainer, that'll happen. The second piece, that's just money. Seems like people are willing to spend money in Washington these days. It won't happen on a bipartisan basis, but to the extent that Democrats are willing to do a reconciliation bill, they'd have to pay for it, because under reconciliation, let's remember our politics here. Remember, under the Senate, there's a filibuster, which says that if you want to do something on a bipartisan basis, you need 60 votes. If you want to do something on a partisan basis, you only need 50 votes, but it has to be primarily budgetary, which exchange subsidies would be, and it has to be budget neutral over the second decade. So you can spend more than you take in over the first decade, but you can't make a long-term commitment that's not budget neutral. That's why you will remember President Bush's tax cuts expired after 10 years. President Trump's tax cuts are expiring after 10 years. Everything expires because they're passed by reconciliation. Well, they wouldn't want these subsidies to expire after 10 years. So ideally, they'll actually have compensation. They'll actually have some fundraising. One idea is to use prescription drug price reform to fund these new expansions. So that's the second piece. The third piece starts to get in the realm of more politically controversial, which is the public option. So let's talk about the public option. The public option really is a bit misunderstood and has two aspects. Let's call them public option light and public option heavy. Okay, public option light is simply saying we have too little competition on the ACA exchanges, more competition with lower premiums. So we need to, the government should try to introduce some more insurance options on the exchanges. Starting up insurance companies is hard, it's risky. The government should essentially fund new startup insurance companies. Indeed, the government did this under the ACA. Startups, new insurance companies would be public insurance companies that offered side by side on the exchanges with private health insurance options. This will expand people's choices on the exchanges, increase competition on the exchanges, thereby lowering costs. In addition, in principle, although the technicalities are very difficult, you could use a public option as a way of sweeping up those uninsured in the states that didn't expand Medicaid. You could say that we're going to offer one national health insurance plan, and indeed anyone who's below poverty in states that didn't expand Medicaid could sign up for this plan. And then that would be a way to pick up those recalcitrant states, bring millions of people into the Medicaid program. It's a bit challenging because that's a private, it's not Medicaid, so there'd be some transitional issues, but in theory, you could do that. That should be pretty non-controversial. And I think something like that, public option light, would have a plausible chance of passing. Once again, nothing that fixes the ACA can get 60 votes, but there's a plausible chance of passing with 50 votes. What President Biden's talked about and what advocates want is what are called the public option heavy. The public option heavy is what I just described, plus that insurance plan would be Medicare. So it wouldn't just be some new nonprofit insurance plan that'd be run by, government sort of stood up. It would literally be government run insurance. The difference with that, and that has one critical difference, which is the government would regulate provider rates. Medicare pays doctors and hospitals sort of 2/3, a half to 2/3 of what private insurance does. So if the public option was Medicare, it could be a lot cheaper than private health insurance because it would pay providers a lot less. For that reason, the minute you go to the public option heavy, you immediately make two critical enemies. Enemy one is the insurance industry, which says, wait a second, this is an unfair playing field. We can't compete with a government that can regulate the rates it pays providers. We'll get driven out. We'll get driven out of business. The second is the doctors who say, look, you already pay us too little for Medicare. Don't start paying us too little for our other patients too. That's two pretty big and powerful groups to take on, even if you don't even want to try to get Republicans. It's not clear you can get 50 Democrats to agree to take on those two groups. So that's the challenge with the public option is will you really, can that public option really be the true public option as Jacob Hacker envisioned it a long time ago, 15 years ago? Jacob Hacker of Yale really came up with the idea of the public option. Can you have the true public option as he envisioned it? I hope that Democrats will not let the perfect be the enemy of the good, that they'll at least get the public option light, which I think could do a huge amount of good. But I don't know. I think a lot of people view that as a huge defeat. And I think they'll either go for the public option heavy or nothing. The other piece that's not being discussed much, but there was a centerpiece of the Biden campaign, was actually lowering the age of Medicare eligibility down to age 60. So bringing a large new set of people into Medicare. That would be a dramatic improvement, I think, because this is a very expensive and risky group that needs coverage. On the other hand, the devil's in the details there. Are they going to get free Medicare coverage? Is this a buy-in to Medicare? If it's a buy-in to Medicare, why is it that different from having them just on the exchanges? So there's a bunch of details that need to be worked out. Plus, it's going to raise the same opponents that the public option heavy raises, the doctors and the insurers. So there's some challenges with these last two pieces of the Biden agenda. So I don't quite know where we're going to see those go. I think, we're going to learn a lot over the next few months on how they want to handle that. And once again, I think what seems pretty clear is anything which is going to be touched to the ACA is going to have to go through reconciliation. So it's going to have to get paid for, or it's going to have to phase out, which no one really wants. Now, you'll notice I haven't talked about single payer, which got a lot of attention during the campaign. Now, in some sense, one reason I don't have to talk about it now, as opposed to while the campaign was going on, is sort of the Democratic Party has spoken. If the Democratic Party wanted single payer, they would have nominated someone else. Now, my children tell me that, I'm biased and Bernie never had a chance and Democratic voters really want it, and da-da-da-da-da. But, the truth is a true single payer option faces three critical hurdles that no one has ever described how they're going to overcome. I am not opposed to single payer. I just don't know. No one has ever described to me realistic how you're going to make it happen. The first hurdle is that it's really, really expensive. Now, it's not that expensive in terms of social costs. Indeed, the best estimates are if we tomorrow woke up with a single payer healthcare system, total system-wide spending might be lower. The difference is it would transition from a hidden tax to an explicit tax. Today, the vast majority of healthcare is funded by a hidden tax. That hidden tax is the fact that Wayne State and your employers pay you less because they give you health insurance. Okay, MIT doesn't spend $12,000 a year on my family's health insurance out of the goodness of their heart. They pay me $12,000 a year less. Okay, and basically that's a hidden tax. Now, if we went to single payer, everyone in theory would get a giant raise. You'd all see a big raise. All of you are insured by your employer, but you'd also pay a big new tax to pay for it. Now, economists would say, well, I'm indifferent. But economists don't make up a very big voting bloc. Other people would say, I don't believe I'm going to get a raise. You're just going to have this new tax. And that's horrible. And we hate taxes. And so that's problem one. Problem two is you've got the vast majority of America, which is pretty satisfied with their insurance now. You've got 170 million Americans with employer-sponsored insurance who aren't very eager to just give it up for some unknown new plan. And that is a really tough political sticking point. And then finally, you have got a $1 trillion private health insurance industry in America that's not going to say, well, it's been a good run, we'll pack it up and just go quietly into the night. No, they're going to fight. And no one has ever described, given that we bail out industries a third that size all the time, No one's ever described how the government's prepared to wipe out a $1 trillion health insurance industry. So for those reasons, single payer simply isn't happening. And I think we need to, it's not happening in the near term. And we need to stop letting the perfect be the enemy of the good. We need to realize the Affordable Care Act was a fundamental step forward, one of those important step forwards for really the fundamental fairness of our society in decades. And we need to build on that as President Biden's proposed to. Now, everything I've discussed, by the way, was the easy part. Okay, all this stuff we've discussed, that's like child's play compared to the hard part. What's the hard part? The hard part is controlling healthcare costs. Okay, now, I don't think that the fact that's hard means we should not celebrate what we've accomplished. We can't really get our healthcare system fixed unless we bring everyone to the tent. But now that we brought everyone to the tent or are on our way to doing so, we need to deal with the fact that healthcare costs are the single biggest fiscal calamity facing our country's future. We are deeply in debt in the foreseeable future due to our ever rising healthcare cost burden. Okay. And we have to address that. The best estimates are that by the end of the 21st century, we will spend over 40% of our GDP on healthcare. That's simply unsustainable. So how are we going to address it? Now, here's the good news. The good news is we don't have to fix this tomorrow. Okay. We can afford to spend 18% of GDP in healthcare, is what we do now. We can actually afford to spend 25% of healthcare in GDP. We just can't afford to spend 50% or 40%. So we have time to fix this. Okay. The problem is we don't really know how. And anyone who tells you they know how is lying. Okay. There is no way we know to truly fix health insurance spending without potentially risking health. I mean, there's ways we could fix it. We just say we're going to not spend any more money and then people would die. So the problem is, while we know there's waste, it's easy to look back and say what that waste is. It's hard to look forward and say what the waste is going to be. So we can say, well, look, Europe does it. Okay, Europe basically controls our healthcare costs. They spend much less than us. They seem to have better healthcare outcomes, or at least no worse healthcare outcomes. What do? Well, they do something we're unwilling to do. They regulate the prices they pay their providers. It's really not that complicated. Okay, healthcare markets, as the economist Kenneth Arrow taught us in 1963, are among the most broken markets that exist. Every aspect that healthcare economists talk about why markets wouldn't function are present in healthcare markets. There's imperfect information. There's imperfect competition. There's all sorts of, there's decision failures. Everything we could think of that makes a market function poorly exists in healthcare. The rest of the world besides the US has recognized that. And they've recognized you have to do that by regulating the prices that you pay for healthcare. And that's how they control costs. There's no magic to how Europe spends less on healthcare. They just pay less for their healthcare. So essentially the question in the US is, are we willing to go that route? Now, so far we've not been. So far we've tried other routes where we try to say, well, we're not going to regulate rates. We'll try to do innovative things like accountable care organizations where we coordinate care and try to put in pay for performance incentives and essentially sort of put sort of bolts and nuts on top of our existing system. It just hasn't worked. Okay. The question is, at what point do we realize that we're going to have to move in the direction that Europe is and start to do some more regulation? And really the issue is we may be facing that point because there is now serious discussion of regulating prescription drug prices. Okay. I was never sure if we'd regulate healthcare prices, but I always said if we're going to regulate, we're coming for the drugs first because their prices are right in our face. People of my generation are pissed off about having to explain to our kids, 10 years ago watching football, why the guy kept throwing the ball through the tire in the Viagra ad. What was Viagra? Okay, we're sick of advertising. True story. There is a pediatrician in my town who had a 9-year-old come to his office and say, I'd like to talk to you about Cialis. And the pediatrician said, what? And the kid said, well, I was watching a football game and it said, talk to your doctor about Cialis. So we're mad at the prescription drug companies because of these advertisements. We see these incredible prices they're charging us, and it's come home to roost in the form of serious discussion of regulating drug prices. And probably the most serious candidate right now is Bill HR 3 in the House, which would regulate drug prices for the top 250 most expensive drugs. The Secretary of Health and Human Services would have the ability to negotiate lower prices. And to provide teeth to that, the price would be capped at 120% of the international average for the prices that are paid for those drugs. That's a very serious regulation that's estimated to save almost $500 billion a decade to the government. Okay, but here is the challenge it faces, which is the immediate reaction of pharma companies is, well, if you do this, you'll kill innovation. And what they say is in some ways true. Part of what finances the incredible innovation, and it's been truly incredible, the incredible innovation in the US pharma sector has been our enormous prices have funded the R&D. The enormous price we pay have funded the R&D that's led to new pharma innovation. And there are estimates that as you shrink the size of pharma markets, companies do less R&D. Indeed, the CBO, very boldly, I think, in the same estimate where they said that, the HR3 would save almost $500 billion over a decade, they said it would result in 30 fewer drugs being invented over a decade, an estimate based on what would happen to market size and stuff. And this is going to be the key hit point on HR3. It's going to be, well, it's going to kill innovation. Here, I think that we've set up a false choice. And here, you know, what I've turned my attention to a lot in the last few years, while I continue to care a lot about healthcare, I've turned my attention a lot to innovation. And in particular, I've written a book called Jumpstarting America with my co-author Simon Johnson at the Sloan School, which is about the fundamental fact that America has lost our leadership in innovation because we've gone away from what truly did make America great. And what made America great in the decades after World War II was government publicly funded research and development. By the mid-1960s, 2% of the entire US economy, one in every $50, was government-funded R&D. Now we're down to 0.6% of GDP. We're 12th in the world. And that is the reason we don't grow like the rest of the world. That's the reason we're not innovating like the rest of the world. Okay? And the lessons are that if we invest more in public R&D, we can have the innovation we're missing. So take a simple study from a fantastic study from my colleagues at MIT, Danielle Lee and Pierre Azoulay. They looked at NIH funding and they compared NIH grant applicants that just barely got approved or just barely didn't get approved. And that can then let them compare what is the effect of getting NIH funding. What they estimate is that every $125 million of NIH funding leads to a new drug. It leads to $1 billion of private follow-on funding. That is, it crowds in, not crowding out private R&D, and at least new drug. So by that estimate, if we took 1/4 of the savings, 1/4 of the savings from HR3 and gave it to NIH, we would have 100 new drugs in a decade, more than the 30 we'd lose from this loss of private R&D. There's public R&D opportunities out there which are incredible. And so bills like HR3 can easily be win-win by taking the savings and making sure we recycle them to public R&D rather than sort of bribing the pharma companies in a wasteful bribe that they spend some of on Cialis ads to do the R&D. And so I think I'm optimistic we can turn to this. It obviously ties very much with President Biden's Build Back Better agenda. I was very pleased he cited our book in developing that agenda in his plan. And he's proposed to spend about $300 billion in new public R&D, which is very exciting. And so I think there really sort of, it does come back to, in many ways, it comes back to this healthcare reform, which is the way to have healthcare savings while we continue to have healthcare innovation is to make sure that we both more wisely regulate the prices we pay in healthcare and also at the same time move towards promoting public innovation and public R&D spending. So I've gone for a while there. It's been about 40 minutes. I think I will stop. I'm happy to go on forever, but Shoshana said Shushan said you might have some questions. So let me pause there and take questions.
Great, thank you so much, John. These were really amazing comments. I would like to remind everyone that if you want to ask a question, please type your question in the chat box, and I will ask those questions on your behalf. And I'm going to start off with a whole bunch of questions that had come in even before we started. And I'm going to start with a question that Amanda Cook and Ron Tracy had asked, which was, well, we know that the cost of our healthcare system is quite high. What are some effective and critical cost cutting margins where medical costs can be cut. And that involves the whole range of medical care, not just hospital care, but prescriptions, tort reform, and all those.
Look, I think that with something, we have to always, whenever you talk about healthcare reform, people fall into black and white thinking, which is this works, this doesn't work. This fixes it, doesn't fix it. We're never going to fix healthcare spending. Healthcare spending, we'll always have to worry about healthcare spending growing faster than the size of the economy forever. The question is, what steps can we take to continuously address it? There is some low-hanging fruit that we can do. We can do much better. I think, honestly, the move towards narrow networks that was really sort of sped up by the Affordable Care Act has been incredibly successful. Although we do have to worry about some health insurance plans discriminating against the sick through exclusively narrow networks. I think by and large, we've squeezed some excess waste out of the healthcare system. I think moving towards more aggressive accountable care organizations can help, but that's all small potatoes. I think really, if we really want to take on healthcare spending, we've got to go after regulating prices. Let me mention a malpractice. I actually did a really cool paper on this with my co-author, Mike Frakes. We had a cool paper because it turns out you can run a sort of natural experiment on this, because it turns out there's a group in America that cannot sue for malpractice. If you're an active duty military treated on a military base, you cannot sue. Your spouse treated by the same doctor in the same base can sue. And if you go off the base, you can sue. So it's a natural difference, a different setup. And we estimate based on that defensive medicine amounts to about 5% of medical spending. So it's real, but it's not transformative. So we could definitely, and my co-author Mike Frakes, an expert on malpractice reform ideas, there's a lot of good ideas we do. So there's a lot of things we can do. But fundamentally, if we're going to really, in a fundamental way, get towards European level spending, really sort of bend that curve, it's got to involve regulating healthcare prices.
Thank you very much. I have a question coming in from Fabrice Similakis asking, beyond drug price regulation, you mentioned all payer price setting for providers as a way to reduce costs. Doesn't this avoid nearly all of the criticism of a single payer system?
Well, first of all, it doesn't address the criticism from providers. Certainly insurers would love it. If we said to insurers, we're going to keep private insurance, but we're going to regulate all the rates, they'd be happy. I think they wouldn't trust it. They'd probably say it's just, private insurers never be happy with government intervention, but I think it'd be happier than single payer. I think, we could think about all payer rate setting. But that has very many forms. So let's talk about what that means. So in the US in the 1970s, we used to regulate hospital prices in virtually every state. Virtually every state had a regulated set of hospital prices, and that all went away, except for a couple states and eventually only Maryland. Maryland still has what's called all payer price setting. What does that mean? That means that whoever pays for your hospital care, they all pay the same price. But that doesn't say anything what the price is. Okay, it doesn't lower prices, it just lowers the variation. Okay, so basically, the question is, are you going to then go ahead and regulate the level of those rates? Okay, and how are you going to do that? Regulation by itself, look, flip the other side of the coin. I've been very glib about the wonders of regulation. It's not easy. The reason states went away from the 1970s is because it was viewed as problematic along a number of ways. Who sets those rates? How do you decide what a fair price to pay is for hospital stays? That's very, very challenging. So I think with drug price regulation, I feel like the reason that's a natural first step, besides the sort of glib reasons I gave, are we think other countries sort of we think drug sort of work the same way in other countries. So it's not clear you can take the hospital rate for a hernia in Germany and apply it in the US. So many things are different. But what they pay for a certain drug in Germany probably can apply in the US. So we can learn more from these other countries. Plus for drugs, we have a lot more cost effectiveness analysis. We have this wonderful organization called ICER in the US, the Institute for Comparative Effectiveness Research. We have NICE in the UK. We have lots of institutions that do real comparative studies of drug value that we can use. We don't necessarily have those for a lot of the things we do in other parts of the medical care sector. So while I think we eventually need to move towards more regulated pricing for other providers, I don't yet know how to do it. I feel like on drugs, HR 3 is sort of a framework that might work. There's pros and cons. Whereas if you said to me, okay, John, write the bill that regulates doctors and hospital rates, I can't write that bill yet. I think we need to move there. I don't think anybody can write that bill yet. I think we need to move there. I think we need to, and I think the drug price regulation is the first step. But But the question raised a good point. Drugs is only about 15% of our healthcare spend. There's a lot more of the bill we need to tackle. And we're going to do some serious thinking about, do we do it? Do we do it? In substance, when you think about regulating healthcare spending on the provider, the hospital and doctor side, you can think about two different paths. One path is the European path, which is literally make a catalog of prices. Go to every price and set it. The other approach is a sort of broader capitated approach, which is to say, look, for this population, we're going to spend X. We're going to have some organizations control all the spending for that population. This is the idea of ACOs, but it doesn't really work. Some organization, it's the Kaiser model, Kaiser Permanente. They've got everything. They got the drugs, they got everything. They get a certain fixed amount. Here's the good news about that, which is very, very important. And that model in principle is much better because you don't have to get into setting administrative price setting of tens of thousands of prices. In practice, it's got the challenge that these organizations are hard to set up and you still have to set the price that you're going to pay them. But here's the good news that I think gets lost too much in this debate. There's so much bad news. Here's a bit of good news. We don't have to lower healthcare spending. We can afford 18% of GDP. We just have to have it stop growing relative to the economy. So no one has to lose. They just have to stop winning so fast. If orthopedists want to keep making $750,000 a year, fine. They just can't keep making $100,000 more every single year. Okay? So the point is that we need bending the curve. If we in 25 years are at 18% of GDP, our fiscal problems go away. The entire long-run fiscal problems of the US are about the growth, not about the level. So the good news is if we can come up with a system, either through Route 1, which is through administrative price setting, or Route 2, which is some kind of cap, we don't have to squeeze. We just have to use it to slow the growth.
That actually kind of brings us to this question of, part of the discussions you mentioned involve the physicians and their willingness to, engage with these reforms. Are there any concerns that physicians would want to exit, would want to stop practicing if we push more of these Medicare insurance types into the marketplace? And are there any way, and especially Dave Anderson was asking about the sustainable growth rate, which was supposed to be baked into Medicare and was never implemented. We're kind of facing these pressures from professionals as well. How is that going to be affected?
Yeah, it's a good question. Economists believe in a supply curve, and we believe that if we force down the price of a good, it'll be less supplied, and doctors are some good like that. And there's a concern that if you pay them too much less, they'll leave practice. I think we are not anywhere near the range of that concern. You are seeing some doctors dropping out of the insurance system, becoming concierge docs, where they only take, be paid on the side. But I think the notion that we're going to see a massive doctor shortage if we pay doctors 20% less, there's just no evidence for it. I think we would see what we saw during COVID, which is a lot more doctor retirements. Some of the older doctors are going to say, look, it's not worth it. But the truth is, in many ways in America, we're in terms of specialists, we're a bit over-doctored in America. It's not the end of the world if we have a few. Our real problem is a shortage of primary care. And so really we need some sort of rebalancing of the way we pay providers to get primary care to be reimbursed more. And specialists, if they're reimbursed somewhat less, I just don't think we're going to suddenly see no orthopedists. The pay is too good. And if we saw a few orthopedists switch to primary care, that'd probably be a good thing.
I have a question here from Sebastian Tello Trio. And the question he's asking is, do European countries have sizable investment in innovation? And does the things they don't spend on higher Medicaid due to pricing regulation then translate to innovation?
Well, that's a good question. It's sort of a detailed. There's a couple answers. So, it is certainly true. The pharma companies are absolutely right that the more money they make, the more innovation they do. That sign is positive. Now, not every dollar goes to innovation, but it's true that the extra money they make in the US does lead to more innovation. And there is in Europe, because drug prices are regulated and drug access is regulated, they do get drugs later than in the US. Okay, some drugs 6 months later, some drugs years later. because drug companies say they don't want to sell them at those regulated prices. But the answer to that is smart regulation, which is to say, look, we have estimates of the value of these drugs, and we should just pay according to those estimates. We should not, there's just no reason the market's going to get that right for drugs, that it's going to get it right, especially when people are insured for their drugs and pay the most for the drugs of the most improvement in value of life. But we have estimates of those, and we should use those drugs. There's clinical trials that are used to prove drugs, and we should use that for smart regulation. And, you know, the other side of the coin is, well, what about innovation in Europe? Well, I think in some sense, European countries are starting to spend much more on public R&D than we do, particularly Northern European countries. I think our pharma sector is still more successful than theirs, but just because they make so much more money here, they haven't put enough public resource in there to compete. But I think we really need to think about moving towards a smart regulation system, and that's what HR 3 envisions. Now, let me be clear, because now I like to flip between good news and bad news. Although this is mixed news, which is Europe is not ready for the big coming tsunami of incredibly effective and incredibly expensive genetic therapies. So I just put out, I have a working paper that'll come out next week, where I've done some estimates with colleagues. We estimate that based just on genetic therapies in the pipeline today, the US will spend $300 billion over the next 15 years on genetic therapies for very rare diseases. Now, these are therapies like Zolgensma for spinal muscular atrophy. Spinal muscular atrophy is a horrific genetic illness that leads to horrible short lives for infants. They're dead by age 2, and it's unpleasant along the way. A company has cured this. I mean, it's a miracle. They literally have invented genetic treatment where it cures SMA, and they're selling it for $2.1 million. Now, that is a bargain. Okay, compared to value of life estimates, literally saving a life for $2.1 million is a bargain. And perhaps as a result, this is the first drug I know of that was introduced at the same price in the US and the UK. Okay, so this is something where better effectiveness analysis doesn't help you because it's cost effective. So the question Europe's going to face, that raises a different question. So far, I've made it sound easy, like you don't pay for the drugs that don't work, you do pay for the drugs that do work. What about when the drugs that do work bankrupt your country? That's going to start to be, what about when we start genetic treatments for cancer, for arthritis, for things that, you know, that are worth it, but aren't affordable? That is going to be a challenge the world's going to face.
Yeah, actually, that's a really good observation. It kind of reminds me of this era where we're reaching higher and higher hanging fruit, where we are potentially having real life extending treatments that are unaffordable to certain populations. So how would programs like Medicare and Medicaid deal with these new drugs? I mean, are we choosing between the poor and rich in terms of access to life-saving drugs?
Well, it's really interesting. Once again, I think it's very important to distinguish between, you know, the drug that keeps the baby alive and the drug that keeps grandma alive for 6 more months. We may need to decide, do we feel the same way about them? Ultimately, you know, this is why economists are not popular. We say, well, we'll value them. And if it, you know, keeping grandma alive for 6 months is not as valuable as keeping the kid alive. And so you shouldn't pay as much to keep grandma alive. And that's why we don't get invited to cocktail parties. Okay.
Indeed.
So basically that's what we need to do, is we need to really do a proper valuation. Now, to be fair, we talked about why healthcare spending is so high. Remember one myth that we need to debunk. One myth is that healthcare spending in the US is so high because we spend all this money and people are going to die anyway. That is not true. We do spend about 1/3 of Medicare spending in the last 6 months of life, but not on people we know it's going to be the last 6 months of life. People who it turns out to be the last 6 months of life. And indeed, research by Amy Finkelstein, Liran Einov, show that actually the amount of spending Medicare does on those they truly know are going to die is about 5% of Medicare spending. So really, in some sense, we're spending money on people who might die, and that's who we sort of want to spend money on.
That brings me to a question by Owen Rice, who asks, how can we incentivize new physicians to go into primary care? I know that there are existing programs that pay off student loans and provide scholarships to medical school, but these are not widespread. And this sentiment is followed up by Anthony Sue, who asks, asking physicians to change specialty requires investment in deferred income and years of residency retraining. So how do we incentivize that? transition?
I mean, I don't think we're going to get the orthopedists who've been doing orthopedics for 10 years to drop down to be primary care. This is sort of a long run reform. I mean, partly it's about money. We overpay specialists. Remember, what's quite interesting is that reimbursement rates for doctors are really driven by Medicare in America, even though Medicare is not the primary payer of doctors. If you look at interesting research by Clemens and Gottlieb, they show that private insurers follow Medicare in setting doctor rates, setting the fees they pay providers. And Medicare, as research by my former student David Chan shows, overpays specialists, underpays primary care because the board that sets the rates, the so-called RUC, is captured by specialists, and they overpay themselves and underpay primary care. So the first thing we do is we need to fix that imbalance. The second thing we need to do is we need to recognize that we don't need doctors to deliver a lot of primary care. We need to deal with the barriers to proper delivery of care by groups like physician assistants, and nurse practitioners who can deliver a lot of the primary care we need at a lot lower cost. And really, we have occupational licensing restrictions, which are really ridiculous in many cases, and which are getting in the way of developing access. So we talk about underserved areas. Both rural areas and very inner city areas are often underserved by primary care physicians. Well, now that we've really realized the benefits of telehealth, put a nurse practitioner there with access through telehealth to a doctor somewhere. That's just as good. 90% of what that nurse practitioner needs to do, she won't need the doctor. She or he won't need the doctor. But for the other 10%, they might, and then they can use telehealth to get there. So I think we need to think more creatively about how to deliver primary care in our country as well.
That's a very good point. And that brings me to a question from Sergio Brulanti Martinez, who asks about the role of technology and specifically things like electronic health records and adoption of technology in hospitals in order to reduce costs. Is there are there any plans in order to bring in more information technology into hospitals to improve cost management?
Yeah, so information technology, we can think of it like a highway. You can't improve transportation without a highway, but just building a highway with nothing on it doesn't do you any good. I feel like this notion that health information technology by itself is going to change things is wrong. It just sets up the preconditions where we can do better things. If we have good health information technology, we can have smarter payment systems. We can have better information flow. But that's not going to happen without proper incentives. So if we build the highway and don't have any reason for the car to go to the next city, it's going to stay empty. If we build these health IT systems but don't pay doctors to use them appropriately, they're not going to do any good. So I think it's a precondition for properly aligning our healthcare systems, but it's not an end to itself.
Kevin Cotter asks about the public option light that you mentioned. The question he asks, wouldn't having these public option lights mean that some states would choose to drop their Medicaid expansion, kind of crowding their insured population into this private, essentially, market where they have to pay out of pocket?
See, that's why he gets to be the chair, because he asked the question. No, all the questions have been great. I'm just being funny. So basically, it's a great point, and I mentioned this. The public option, the clear advantage is there's more competition on the exchanges. The theoretical advantage is it provides a venue to get at these 12 states, 12 constituent states. But Kevin's right; it's hard to know how you do that. If you make it too attractive, the states that already expanded Medicaid will drop and go on that. If you don't make it attractive enough, these states won't take it up. So that is the needle you have to thread, is how can you use this public option to bring those states in, bring people from those states in without getting other states to back off what they've done. Kevin, I don't know the answer to that.
Fair enough. And again, it kind of feels like this was a similar struggle when the Medicaid and the health exchanges were opened up, and there was this concern that a lot of employers would be pushing their employees to go on these exchanges and preferring to pay the employer penalty rather than provide insurance to their employees.
Yeah, this is fascinating because it's part of the way I got involved in healthcare reform was through computer modeling of healthcare reforms. And so essentially I developed a computer simulation model that first Governor Romney used and then the Obama administration Congress used to help sort of model healthcare reform. And one of the biggest inputs to that model was the question of how much employers would be crowded out of providing insurance. And we have this difficult problem, which is all the microeconomic evidence, all the studies that I've done and others have done, show massive crowd out. But if you looked at what happened in Massachusetts, there was no crowd out. There was actually any crowd in. Employer insurance went up. So we had this difficult decision of how to model that. We sort of split the difference that there'll be some crowd out. It turns out with the ACA, there was once again very little crowd out. It was more like Massachusetts. It is sort of taught you the hazard of sort of using partial equilibrium models to talk about general equilibrium reforms. There was so far very little crowd out of the ACA.
Yeah, I think I've seen a couple of papers that try to estimate this private crowd out, and it's not, they find some effects but not large effects, and that's been impressive as well. I'm going to switch over to prices now, and Liming Kai is asking, speaking of setting healthcare prices, other than administered prices or capitation, do you think there are some other alternatives to setting prices like bidding, or how do we implement reform to healthcare pricing?
Yeah, so I think this is really interesting. You could certainly imagine a world in a place like Detroit or Boston where there are a series of truly integrated accountable care organizations that cover people for all their medical spending, and they bid to cover people in a city. So you could say, look, there's 4 of them in Detroit. Detroit's big enough they can split it up. They bid. You could imagine first level bidding where they bid to be the monopoly for the city, or second level bidding where they're on an exchange where they compete and people can choose. And then that's the beautiful outcome, right? Then the government doesn't have to get involved in regulation. The market reveals it. The market reveals that they have to pay. But that only works in a competitive market. The problem is, even in a city like Boston or Detroit, you're not going to have enough options. That's going to be a competitive market. You're going to have 3 or 4 options.
Mm-hmm.
Okay? It's not going to be competitive enough. And in most of the country, you won't even have one option. So in theory, we wouldn't have to have the government set prices. We would just say, look, let's set up a mechanism where everybody's in these ACOs, so the ACOs compete and let the market set the price. In practice, that market is never going to work. Now, I am more confident. It's actually a great story. One of my favorite stories in health economics was my colleague, Peter Diamond. Some of you may know, or I'm sure you all know of his work, Nobel Prize winner. Unbelievably smart guy, does unbelievably complicated work. And he was elected president of the Econometric Society, which is, where the unbelievably complicated work gets done. For those who don't know, it's like the high-tech society in economics. And he gave his presidential address, and everyone was ready for him to give this high-tech address with a bunch of proofs and math. And his address was a plan for national healthcare reform. And his plan was essentially first stage competition, that there would be that insurers would bid in a first stage and the winner would insure an entire area. And there'd be no issue of adverse selection because they'd insure everyone in the area. And then, of course, they coordinate care for the whole area. And I, to this day, think that's kind of a cool model to be thinking of. And you think that first stage competition might work, but it still wouldn't work well enough. So I think I really like the idea of what I called Route 2, rather than setting regulated prices, actually having some sort of capitated system. I just don't know how you set what the price is for that capitated system. Although, once again, I'll say you don't really have to get it right as long as it doesn't grow too fast. So if we say, look, this is what it costs today, we're going to set it what it costs today plus 20%, but it's only going to grow at 2% a year, our long-run problems in healthcare are solved. The problem is, someone mentioned the SGR. This is an example. We tried to regulate physician rates. We got it wrong. So physician rates were set too low. So we essentially just bought the physicians out of it. So the problem with the capitated solution is, do we hold our line or do we eventually just let it go up? And that's the challenge.
So the next question I would like to ask is going to be an amalgamation of a whole bunch of questions, one by my colleague Mike Belzer, as well as David Krzyzewski and Ron Tracy and David Schwartzman. And the question is, okay, are we moving away from private market solutions to healthcare? Does the employer provided insurance scheme still need to be at the heart of our healthcare system? And or are we gradually moving away from, towards away from this Reaganomics kind of a strategy of providing healthcare?
Well, first of all, it's not a Reaganomics. The employer healthcare system really was birthed in World War II, when, due to wage and price controls, firms realized they get around wage and price controls by paying their employees in benefits instead. And the employer-sponsored insurance system was born. There was then an IRS decision which ratified the notion that your compensation is not taxable if it's in the form of health insurance.
Mm-hmm.
That's a big reason why employers provide it. So essentially, here's how I think about it: employer-provided health insurance. I think of it like a building that's crumbling. Okay. The base of that building is big employers who have large health insurance pools. They're good at administering health insurance and they get a huge tax break to do so. The employers don't get the tax break, their employees do, because their employees are not taxed on their compensation that comes more of health insurance. Okay. That's the base of that building. But as you go up the building and firms get smaller and health insurance becomes harder to run and less central, firms are more or less indifferent. And as a result, the building's been crumbling. And over the decade before the Affordable Care Act, through good times and bad, employer-sponsored health insurance fell by about 1% a year. So the building was crumbling. With a crumbling building, you face three decisions. You can try to repair the building and prop it back up. That would do things to try to subsidize health insurance among employers. You can knock it down or take a real hammer to it. That would be something like removing the employer-sponsored health insurance subsidy, which I would strongly advocate, but could knock the whole building down. Or you can set up a net around the building so that those who have to jump have someplace that they're caught. And that's what the Affordable Care Act did. We'll essentially say, look, we're not going to expedite the crumbling of the system. As we just discussed, we didn't have crowd out. We're not going to expedite the crumbling system, but we're not going to prop up a system that fundamentally has problems as well. We're just going to give people a place to go as this system slowly falls apart. I think that's a sensible solution. Politically, it was sensible. The precursor to the Affordable Care Act was the Wyden-Bennett bill. The Wyden-Bennett bill was like the Affordable Care Act, but it would have gotten rid of employer insurance. And that was just a step too far. So I think, I think that's a natural place to be. The employer-sponsored insurance system has huge problems. First of all, as I said, this tax subsidy is an incredible inefficiency. It is the one thing on which all health economists agree. And if any health economist doesn't agree, you have to tell them they're no longer a health economist, which is that we should not have this incredibly inefficient regressive subsidy. Let's remember how this works. If MIT comes to me and says, John, would you like a $1,000 raise? Or would you like $1,000 in orthodontia benefits for your daughter? I say, well, if I get a $1,000 raise at today's tax rates, state, federal, payroll, I'll take home about $550. Okay. If I get $1,000 orthodontia benefits, I get $1,000 orthodontia benefits. So I do that. My daughter has these cool braces that spin and change colors. And every month she gets new ones because why not? It's insured, it's free. So the system has three big problems. One, it's expensive. If we taxed employer-sponsored insurance like we tax wages, we would raise $250 billion every year, much more than it would cost to cover every uninsured person in America. The second problem is it's inefficient. Because people are buying health insurance with tax-subsidized dollars, they buy too much of it. And the third thing is unfair, because the higher your tax rate, the bigger tax break you get. We send to a system, we bribe people to buy insurance through their employer, and the richer they are, the bigger bribe they get. So that's terrible, but politically, it's a nightmare. Actually, one of the most amazing things of the Affordable Care Act, I can't believe it got it through, was the so-called Cadillac tax, which would have tried to tackle this. It's eventually been repealed. It's just too hard a political challenge. Mm-hmm. So I don't think you can tear the building down, but I think you need to be prepared as that building crumbles, and that's what the Affordable Care Act is trying to do.
And that brings me to a question from Phil Levy, who asks, does disaggregating preventive care from acute care in terms of insurance, in terms of payment systems, make sense?
Well, that's okay, so let's take the two sides of it. It's a good question. It's a hard question because your preventive care is my acute care. So it's a hard question because there's no clear line. I think you need to start with the obvious piece. I think we need to really think about care. One bucket of care is what we call maintenance care, care that is obviously needed and cost effective, like low-cost medications for diabetes. That should be free. Indeed, we should probably pay people to take it. And we should do everything we should be reimbursing providers based on the share of their patients that are actually taking care of that low-cost maintenance. Then there's the second piece, which is what I'm going to call preventive care, getting your visit every year, things like that. There's no evidence that actually saves money, but it's cost effective. Remember, we have to have a difference between cost saving and cost effective. Cost saving is pretty rare. Things like low-cost generic diabetic medication is cost saving. Literally, you save money by people taking it. Generally, preventive care is not cost saving, but it's still cost effective. If you look at what it costs versus the health improvements it induces, it's cost effective. And we need to make sure providers are reimbursed sufficiently to provide that and make sure individuals are not deterred from getting it. But free is a different thing, because, where do we draw the line on what's preventive care versus someone being a hypochondriac or just someone going for lots of care that they don't need? So once again, with the Affordable Care Act, which actually, it's funny, this is literally picked up from Massachusetts. We sort of split the baby, and we said that the first 3 preventive care visits per year are free, and after that, you pay cost sharing. So we tried to sort of split the baby that way, but it's hard to know how you draw that line, and that makes it challenging.
Indeed. So a couple of more general questions coming up. I have a couple of questions about developing countries who are currently in, struggling with COVID, and they themselves are thinking about their own healthcare systems. Are there any conclusions that we can draw from our COVID experience that a developing country might find useful in how they shape their, what priorities they give in their healthcare system?
Yeah, it's a good question. I'm really worried about the slow pace of rollout of the vaccines in developing countries. I think one thing we can learn is, look, Operation Warp Speed was by an order of magnitude the best thing the Trump administration did. And basically, the federal government delivered this miracle that is vaccination for COVID. I mean, it's really a miracle, okay? Unfortunately, the federal government undershot, if anything. We did not prepare enough to make sure the whole world got this treatment. It's not that expensive. For 10 or 15 billion more dollars, which is chump change right now, we could get a huge share of the world vaccinated, and we should be doing that. In terms of healthcare systems, it's interesting. I don't know quite what the lessons are. It's not like single payer systems did a whole lot better than private systems. I don't know if there's such great systems for lesser healthcare systems. I think the great lesson is really for sort of trust in healthcare in public health networks. And if people would have just worn their masks, we could have had such a better result in the US. And so I think it's really about how do you get a system where there's a trusted source of health information, and with the growing sort of source of conspiracy theories and individualized view of truth all around the world, how do you get there to be common sources of trusted knowledge in both developed and developing countries to deal with problems like this?
And that actually naturally brings me to a question that Mary Beth O'Connell and Stephanie Price Cumming were asking, which is, misinformation and myths about health and health insurance are endless. And we live in a time right now where we have deep political divides. And it seems that even health policy is split along political divides. How do we overcome these kinds of misinformations and divides, and really bring in the both sides on this issue of we want to improve everyone's health?
That is the fundamental question. I mean, the thing I like to say about healthcare is if you take the ratio of how much people actually know about it to how much they think they know about it, it's the smallest ratio in existence. That is, everyone thinks they know a lot about healthcare. I'm not exempt. So literally, I had a rash my doctor couldn't explain. I went online, saw that it was a sign of COVID. I said, my doctor said, haha, you missed it, I have COVID. I went and got a test and I didn't have COVID. He was right. It just wasn't the right kind of rash. Okay. Basically, everybody thinks they know more about healthcare. Okay. And basically that makes it perfectly ripe for the echo chamber problem. The problem that we all find the information that validates what we think and not the information, which is the hard truth. And that is just, so it's really sort of the sweet spot for the problems we're facing with the misinformation economy today is healthcare. And I don't, it's really challenging to know what to do about it. Here's the, once again, here's the kind of challenge that really, every once in a while you read an article which really just sort of opens your eyes. So I ragged on pharmaceutical advertising, okay? There's a fascinating article by Amanda Stark, which shows that actually advertising for cholesterol lowering drugs direct-to-consumer advertising massively improved the health of Americans, because many Americans weren't going to their doctor and asking about their cholesterol lowering drugs. And it was actually worth the spending advertising. So there's no simple right answer for what we should do. The misinformation problem is obviously enormous. I just don't know, honestly, how we address it. And it affects everything from our politics to our healthcare system. I guess the difference in healthcare is I'd like to think is there's some objective truths we can try to get out there, but it's just become increasingly hard. I mean, it's just the long-winded way to say I simply do not know, and it worries the hell out of me.
I have two more questions, and they're both from students. And the first question is from Gabriel Castor, and she asks, will you be working with the Biden administration to make improvements to the Affordable Care Act, to implement these changes that you discuss?
I'm certainly sending them my ideas. The thing about being outside the Beltway is, you know, I know who they are. I have their email addresses. I can send them ideas, and then I have no idea what happens. So I'm trying.
And the second question is from Manat Bedi, who is a medical student, and she asks, do you have any advice for students, for undergraduate and graduate students, in how to help with reform? You know, Manat specifically is in medical school, so from her point of view, she's training to become a doctor. What are some things that students should be thinking about?
You know, it ties to the last question, which is basically, how do we as experts effectively convey truth? And it comes down to not being pedantic or snooty, but really just meeting the patients where they are and helping them understand the truth. I think really it starts, act local, think global. It really starts with, when you go out into practice, really talking to your patients about good health behavior, about truths, and really working through your professional organizations to try to make sure that the truths get out there and the patients get informed. It's really about effectively talking to your neighbors and, really when your neighbors say things like, I hate Obamacare, I like the Affordable Care Act, don't laugh at them. Say like, oh, that's interesting. Well, the Affordable Care Act, and then come around to the fact they're the same thing. It really is kind of about, I feel like, a lot of we experts complain people don't listen to experts anymore, but we bear a little bit of the fault, which is experts increasingly don't talk to people anymore. We talk to ourselves. As society becomes segregated, we're not talking to people who aren't like us anymore. And I think it's really a matter of how, taking your expertise and conveying it to everyone.
I would like to thank you, Dr. Gruber, for this really amazing talk and a really amazing set of answers to the questions. This was very engaging, very lively, and the chat that was happening in the background was also very lively. I would like to thank you for your visit. This was a wonderful opportunity for all of us to learn about the future of ACA. And I would like to end our lecture on this note. Thank you so much for your visit.
Thank you very much for having me.